Hello and welcome to the podcast. Date of the recording is 23rd March 2016. I'm Shelly Ferrel, your friendly neighborhood anesthesiologist. We're going to talk about lower extremity peripheral nerve blocks. Proceed. Usual disclosures. I have no financial disclosures to report, and all the information contained herein is part of UK Healthcare's patient safety evaluation system. So what we're going to do for today's podcast is we're going to look at ultrasound images of lower extremity blocks. We're going to look at the anatomy and the relative structures that we should be identifying within these imaging segments, and look at the risks associated with the blocks themselves. So we're going to be looking at lumbar plexus, obturator, lateral femorocutaneous, femoral, saphenous, sciatic, and ankle blocks. It's pretty much about everything that will be commonly used to block lower extremity. So as we're looking at the lumbar plexus block itself, it's a pretty extensive block covering 5 segments of nerves that are kind of feeding down from the root structures that kind of come together to confluence that is the brachial plexus that feed into largely the anterior, medial, and lateral lower extremity within the upper thigh. So looking at the cadaver image on the left, we have the psoas muscle that's been reflected, also the kidneys, ureters, aorta, vena cava, all those things have been taken out as well, so that we can kind of see from the front to the back, so that if we were driving the needle from back to front, things that would be anterior to what we would be, or how we would be driving the needle. So as we're looking at the ultrasound image on the left, I use the ultrasound as a guide to let me know where I need to be inserting my needle such that I can get the needle to the segments that I want where the lumbar plexus is, as indicated in the ultrasound, kind of just anterior to the transverse process. So I'm looking for 3 things. I'm looking for where the transverse process itself is located, which typically, as you're feeling kind of the intercostal line, kind of the hips and segments above, you would be crossing over to about the 4th spinous process segment, L4, and here they're imaging kind of a level above that. And so you see that just past the transverse process segments themselves is where we're shooting for the lumbar plexus, which generally can be a 2.5, not quite 3 centimeters or so past where you're contacting the osseous segment from that. So identify location, depth. So as we look at this particular ultrasound imaging, we can see that the plexus itself is somewhere around 5 centimeters, and the osseous segments themselves are probably somewhere around 3, 3.5, 4. Also keeping in mind that as we're pushing this probe against the skin, we are depressing soft tissues as we're pushing in. So we're taking out, about 1 centimeter. Some patients may be even up to 2 centimeters of slack, such that when you're driving your needle, you're going through more tissue. You're going to have more depth than what you're appreciating with the ultrasound because you're compressing that tissue and taking distance out of it. So that's one of the things to be mindful of as we're anticipating depth of this. The third thing that I'm looking for is generally laterality. I'm looking for how far out am I going to pan this ultrasound beam before I'll lose those transverse process segments, to kind of give me an idea of a safety window of any kind of needle pass outside of the segment isn't going to contact transverse process and may land me somewhere in the adventures of the peritoneum. So with those particular ideas in mind, I'll use the ultrasound to give me an idea of the ballpark of where I'm going for this block, but not necessarily use it in real time with it, as we are trying to navigate the needle. It would almost necessarily be an out of plane. In-plane approach would be very obstinate for trying to get the angle that you would need to navigate the transverse process. Additionally, it would be a fairly steep angle, so your overall appreciation of the needle itself would be very challenging to get to the segment that you need to be to in a safe fashion. So because of the mechanics of how this would be accomplished, it's typically easier for the patient, easier for the proceduralist to get an idea of where you need to be with your needle, but then conduct the block itself more conventionally without the use of ultrasound in real time. So classically, this block was done. Patient can do it sitting up, lying on their side. Doesn't really matter quite as much. Not like an epidural. Whereas you are identifying midline, which are the little circles that are on the picture that's on the left, typically about 5 centimeters directly off of where you're anticipating the projection of that spinous process as your insertion point. Again, they've kind of identified kind of the intercrystal line with that little A marking, and you see the little lines coming down towards midline, and then anticipating that you're going to be contacting transverse process there. So with the actual conduct of this block, what we're trying to do is hit the transverse process, and then I'll either go above or below. Typically from the L4 segment, if I'm trying to get something that's kind of up in the hip, a little bit more the proximal segment, so I'll have the resonance directed a little bit more cephalad and make that pass above in that direction. If it's something that's kind of like, femoral neck, somewhere, around the joint, below acetabulum, I'll have them directed below. It really doesn't matter in terms of the overall space that you end up, because the lumbar plexus itself is fairly contiguous, so you'll still get spread into those other areas, but you get a little bit more targeted spread kind of with those adjustments if you can get the needle access point there. So typically your contact point, the basic mechanics are hit the bone, go above or below, get past it, typically 2.5 or so centimeters past that. You'll also notice that the proceduralist is wearing sterile gloves, so whatever we anticipate the depth to be, I'll judge what the safe depth should be and have the residents grasp the needle at that safe depth, such that once their gloved hand is touching the skin, then we need to be readdressing that angle of where we're driving our needle to try to get that osseous contact that we want. Typically, if the resident is introduced the needle and doesn't have any osseous contact whatsoever, I'll have them take the next direction a little bit more medially, anticipating that maybe we have missed the osseous contact somewhere in a lateral fashion, or maybe the transverse process itself doesn't project quite as far laterally as what we want. If we have persisting osseous contact, then typically I'll have the resident direct the needle in kind of the opposite direction, kind of a either superior or inferior, and then a little bit lateral to try to get away from that osseous contact, as sometimes if it's persisting osseous contact, we may have kind of traversed a little bit closer to kind of the pedicle or laminar segments that are a little bit more midline, and we're just trying to negotiate just past those structures. So our coverage from this particular segment is going to be lateral femorocutaneous or femoral or obturator, genitofemoral, iliorenal, iliohypogastric. We can do it with or without ultrasound. Like I said, there are lots of proceduralists that do demonstrate use of ultrasound with this, but having done it both ways, I find procedurally is a little bit easier conduct, kind of getting rid of that extra step that can sometimes get in your way more than help you. The nerve stimulator I generally will use with this as a function of demonstrating that, if you get the needle in, you got your osseous contact, you get past it, you get stem, you can pretty much hang your hat that you're exactly where you need to be. So that's textbook execution of the block. So the other thing the nerve stimulator affords you, in addition to demonstrating that you are near the nerve structures that you want to be near, looking for stem kind of in the anterior thigh. Ideally, you're kind of looking for the femoral stem, but pretty much anything in that segment, whether we've got sartorial stem or any of those things that are giving me some sort of associated motor pattern in the anterior thigh. It also demonstrates that as you're adjusting the amperage of your nerve stimulator, and I'll have initially the nerve stem dialed up between 1 and 1.5. As we're dialing it down to demonstrate our proximity of the needle to the structures that we're targeting, if you generally kind of get dropout and loss of the stem, somewhere around 0.4, 0.5, that's a great location. You're right on top of it. You can take it there. But generally, if you have kind of a really, really strong stem, banging stem at like 0.2, then you're probably a little bit closer than maybe perhaps you need to be, because one of the other risks that I don't have completely delineated below is that you could be kind of in the neural sheath, maybe have some spread into the sacral nerve axis, depending on how those connective tissue segments are layered with one another. It would be very fortunate to have a large 30 ml volume of 0.5% ropivacaine project itself into the cerebral spinal fluid if you're in kind of a nerve root structure that translates into that space, and certainly in that extreme proximity as well, you could have kind of creeping along those fascial planes that would give you almost kind of a neuraxial spread, almost kind of an epidural type affect. So the nerve stem kind of gives you an idea if you're in some sort of conductive segment that probably you may be a little bit closer if you have a very strong stem at a very low milliamperage, 0.2, 0.3 with a strong stem. I'd back off that a little bit. So the other structures we're trying to avoid: kidney, ureter, aorta, vena cava, depending on the side, and risk of retroperitoneal bleeding. So I will also treat this like I would a neuraxial type block. If so, any patients that are on anticoagulants, Coumadin, therapeutic Lovenox, things that I wouldn't put an epidural in, I generally get a little bit more shy of trying to go for this block for that reason, is that the retroperitoneal space can hold a tremendous amount of blood, and if you have put a needle into someone that could be at risk for sustaining bleeding within a very large space, you might find that you have taken a substantial risk in that particular venue. So I get a little bit more concerned in that particular clinical situation. So moving down further into our branches of this segment, so obturator nerve blocks, as we're looking at our image on the left here, where we've got our ultrasound probe, and conveniently they've shaved the leg in a very kind of anti-Sasquatch pattern. We have imaging that's just below the inguinal ligament. We have needle approach from lateral to medial, as on the screen, the right side of the screen would be medial, the left side of the screen would be lateral. And as we're looking at it with the ultrasound image that we're trying to capture here, you're looking at the adductor segments. So we have adductor longus, adductor brevis, adductor magnus. The generic mnemonic that I developed to help me remember this, LBJ was the president, LBM is our adductor segment, so we're looking for this obturator block. So whatever it takes to help you remember it. So in this particular orientation, this is largely a sensory nerve, so I don't particularly bother stemming the obturator. My clinical uses for this block are things that have been like a total knee arthroplasty or an ACL repair or some sort of knee scope that's generating a substantial amount of pain. So patients that are having sustained pain patterns despite whatever other things that you may have done in a medial aspect, so the inside of the knee, generally it's not commonly described where it would be kind of just where some of the quadriceps segments that are just above the patella or even almost extending down to the knee joint itself. So this sensory segment would cover that aspect if you put in some sort of other block like a saphenous or femoral nerve block, and you seem to be having sparing of the medial aspect. Typically, I'll put the hydrosection volume as we're looking at the obturator nerve in the posterior branch that's in that segment between adductor brevis muscle and adductor magnus muscle. And it's almost like a tap block. So this is kind of a fancy field block. Like I said, we're not really getting much motor stim here, but we want to get right into that plane such that when we're putting our volume in, it just kind of parts the curtain so you get that nice black cloud that kind of runs the width of the screen. I do the deep segment first within that posterior branch because as you put volume and things in superficial segments, anything deep to that may be obscured by the volume or if you have any air in that ejectate. So it makes the identification of the discrete layering segments in the deep more challenging if you've done the superficial injectate and then gone for the deep injectate. So typically I'll go deep first and then superficial. So again, kind of bring the needle up a little bit. Now, you always see these beautiful pictures on all the websites and things where they've got all these discrete hyperechoic structures, and this is the nerve right here. It doesn't commonly look like this. You're really just trying to almost do like a fancy lower extremity tap block where you get into that plane, you get your hydrodissection, you kind of spread those layered segments apart, you get a good block from it. So, but they have a very beautifully discretely labored obturator nerve, the anterior branch there. It doesn't really look like that. Just get into that segment, and you can see the layering segments between the adductor longus and adductor brevis. It's like, if you confabulate kind of the letter C right there that's kind of wrapping itself around the adductor brevis, such that your hydrodissection volume just kind of splits, longus and magnus for your superficial injectate, and brevis and magnus for your deep injectate. So again, medial aspect of the leg, we have this is a supplementation that I'll use for kind of medial sparing for knee surgeries. Don't stem it, and there's no major vessels here. It's really just the muscle segments. I have one time seen kind of aberrant arterial and vascular structures that were between longus and brevis. Like I said, I've seen it once. I haven't seen it since. It was a year or so ago probably. So just kind of an abnormal presentation. It was very distinctly appreciable on ultrasound, and we were able to negotiate around it. So that's the nice thing about being able to see things to not hit. It gives you an anti-bullseye. So the lateral femorocutaneous nerve, another sensory segment that's largely involving the lateral aspect of the leg. So as we're looking at our cadaver dissection on the left side of the screen, again, they always have these very discreetly labeled lateral femorocutaneous nerve. It doesn't really look like that in an ultrasound. I've got another picture to follow to kind of show you the landmark structures that you're looking for delivery of your local anesthetic for this block. Then you see your sartorius muscle there as well. That is the primary landmark for what you're looking at as you're looking for your space where you're going to put this volume. The probe itself, as we're looking at the picture on the right, is just below the ASIS, the anterior iliac spine. And so you can kind of take it in the inguinal crease. You can come down a little bit. The punchline of the joke is you're really kind of identifying kind of that lateral border and again, the C shape, kind of like what we're looking at for the obturator, where the sartorius muscle is. So looking at our imaging picture here, you see the sartorius muscle identified there again as we're looking at our Sesame Street Cookie Monster letter C identified in that space. Lateral femorocutaneous nerve, again, they're discreetly identifying it within that segment, but I typically will spread this volume around a little bit just because some of those sensory segments do take a little bit deeper course around the sartorius. So I will make my first injectate volume kind of on that deep layer of the sartorius and that what would be that hyperechoic line just below where the words fascia iliaca are indicated. I would put some volume in there just to kind of, again, like almost like a tap block for the leg where you're kind of getting a lengthwise running of hydrosection volume in that, and then I would come up and put volume right where they kind of got the LFCN indicated, and also trying to get kind of just a black hydrodissection cloud that separates those muscles. Because of the superficial nature of this, I typically don't put a terribly big volume in this particular space. I'll put usually 10 to 15 mLs, just depending on how much of a hydrodissection that I'm getting to kind of get those segments to separate and just kind of get a whole, almost C-shaped hydrodissection around that lateral aspect of the sartorius muscle. This is stuff that's generally good for the lateral leg. Typically, when I'm doing this block, the patients almost always classically will, have had something in the knee, and they'll describe pain, of the upper outer segment of the patella is usually about 2 centimeters proximal in the thigh, and then about 2 centimeters lateral, almost in that divot between the vastus lateralis segments and the quadriceps muscles that would be anteriorly. So nice sensory distribution, no real motor segments within this. I've never really seen any major vessels or anything within this, so pretty low risk of bleeding. It would be easily compressible. So the femoral nerve. So as we're looking at femoral nerve blocks, pretty common block that a lot of residents in the United States will do. So it's your nerve artery vein complex that the anatomists beat into you with their pneumatics, the navel. The most common thing that I will see residents when they're new to this block doing is that it will allow the ultrasound probe to fall within the kind of the groove of the inguinal, or the inguinal ligament is in that line. And so if we look at the cadaver dissections of how this is, we get better reflectance in ultrasound imaging when we have a perpendicular view of this segment. So rather than have the probe immediately kind of take that oblique cut, which is indicated by IL, by our inguinal line there, I typically will have the residents, if they've done that, in this particular instance, as it's a right leg, would have the resident kind of rotate the probe probably about 30 degrees or so counterclockwise, so that the probe is oriented in a truly perpendicular fashion to the leg itself as it's running down. And that crosscut tends to give you a little bit more delineation, give you that truly discrete hyperechoic triangle. It's the femoral nerve just lateral of femoral artery and femoral vein. So this is a segment that's covering our anterior thigh. Now this does have motor segments to it, so you can stem this. Now I will tell you that as we are stemming this, probably one of the more common things that will happen is that you'll get kind of that sartorial segment that's coming across, and distally around the knee joint itself will be kind of a medial stem. In that particular instance, when you're getting that stem, so the good news is you're really close to the segment that you want, that is the femoral nerve, but you're just above it. So typically I'll identify where my residents have placed their needle. I'll have them come back, take a little bit steeper run, and come into a spot that's literally just below, on looking at the ultrasound screen, just below where they got that kind of sartorial stem. And typically the femoral nerve will be right there. On occasion, you'll have some variance in the course of the femoral nerve that may be out further laterally than what you're appreciating. Typically, that's a more common manifestation when the imaging is done below the inguinal crease, so you're down the leg a little bit further. And it's typically, it can be up to, I've taken it up to 2 to 3 centimeters lateral to the vessel. So typically if we're not getting stem where I want it, that's right next to the vessel in whatever hypercoic triangle, within what would be kind of the bottom third of the femoral artery that we're appreciating, and just have them kind of slowly walk the needle out laterally until we get some sort of stem segment out in that direction. So this is pretty good coverage for the majority of knee surgeries that are done in the United States with total knee arthroplasty and ACL repair, things that are fairly noise susceptible in terms of surgical impact. Obviously the vessels are right there, so there's always a risk of puncturing those and bleeding or delivery of local anesthetic into a blood vessel, which is no bueno. Do not inject into vessels. Your patients will not like it. Always a risk of damage to the nerve because it's a pretty large, discrete structure. The biggest problem that we have at our institution, where we have some orthopedic surgeons that do not favor the femoral nerve block, is because patients can fall after this block, and it's one of those known possible complications. Can be very clinically substantial to the patients. They can tear up whatever total knee arthroplasty they've had. They can bleed. Lots of very negative outcomes that make this a less favorable block for some of those patients that would be at risk for that. So we're going to talk about a little bit of the saphenous nerve blocks. That's kind of the adjustment for that, for meeting the needs of the surgeon and not providing a risk situation to the patients. So the saphenous adductor canal block is kind of a modification of what has been adapted for meeting the needs of what the surgeons want to have a reasonable sensory coverage segment without having so much of the motor affect. So as we're looking at our imaging segment on the left here, we've got imaging within kind of the medial aspect of the thigh, and then looking at our cadaver dissection right here, we're looking at the femoral artery. So this is kind of subsartorial, so just below the sartorius segment right there, we see our adductor magnus. These are kind of almost like mirror images of one another, where the adductor segments would be a little bit more, I guess, medial to the segment. But the punchline of the joke is that as we're looking at where the ultrasound probe on the left picture is placed, we typically will approach from lateral to medial. Now, this is clinically significant because the majority of the time, as they're identifying the nerve segment, it's on kind of that lateral aspect, that lateral approach. Now, that being said, having done this block for the last 2 years now, I find that 2 modifications make this more beneficial for giving the coverage that you want, but still providing an adductor canal type block that your surgeons are looking for to have sensory effect without the motor. So the 2 adjustments that I've used clinically with success to kind of meet everyone's goals is to take the block actually higher than what you see in this particular ultrasound imaging. So I will take this block, as close as 5 centimeters or so away from the inguinal crease. So from where this relative probe is placed, anticipating about where the inguinal crease would be, I'd probably would be another 4 or so centimeters, even more proximal than that, going up towards the inguinal crease. So the second adaptation that I have utilized successfully, and again, this is anecdotal, I don't have any kind of evidence-based medicine to substantiate this argument, but there may be some sensory segments in kind of that medial aspect. So what I'll have our residents do is I will have them put a small volume on that medial aspect. So as we're looking at the screen, we've got our femoral artery indicated there, and then just to the right of that a little bit is where the nerve segment's indicated. On that opposite side, on like the 11 o'clock position, kind of between the adductor magnus and sartorius, in that plane on the other side, I'll have the residents put a small volume there for whatever segments may be going medially or kind of fanning out. And those 2 adjustments, at least clinically, seems to, at least in my experience, have reduced our relative reblock rate, or having to go up higher to femoral nerve block to compensate for patients that are having sustained sensory affect and pain after surgery for knee surgeries. So anterior thigh coverage, again, we're in a segment where we're not getting much of the motor affect. So looking at this imaging segment right here, obviously the it appears that the needle segment seems to be coming in from left to right, and again we're below that sartorial segment in the hyperechoic segment. That's just as we're looking at the vessel as a clock face, which would be the 9 o'clock position there. Again, I typically will have the residents kind of come over to the 3 o'clock position relative to the vessel and put a little the local anesthetic in there, just kind of get more of a comprehensive surrounding. I don't know that I've seen anything from the literature standpoint to really strongly validate that. It's just was clinically trying to adapt different ways to do this to get better affect, because when we first started doing it seemed to have a pretty high rate of failure in patients that were having sustained nociception after we'd done these blocks, and for whatever reason we had to adapt the way that we were approaching them to try to get the benefit that had been described in tons and tons of papers. So effectively we weren't doing them in the best way that could be doing. So it's kind of a learning cause and effect adjustment. So obviously you're very close to the vessel with this. So this is probably one of the blocks, barring like an axillary block that the residents not uncommonly will on occasion kind of get into the vessel here, because we're trying to get so close to where that sensory segment is right next to the vessel. So fortunately it's soft tissue, it's easy to compress. That's usually not a catastrophic event, but something to be mindful of. But it does, depending on where you're taking the block, have a slightly increased incidence of some sensory component sparing, where patients may still have some persisting pain after knee surgery despite having had a nerve block. So the sciatic nerve itself, multiple different approaches. So anterior approach, fairly kind of a fun block to do, but you have a lot of tissue that you have to get through to kind of get to the nerve. So as we're looking at the ultrasound image on the left, what we're really looking for is the femur. So we're putting our probe, like the picture on the right, we're kind of on that medial aspect of the thigh itself. The nice thing is, the femur is a big structure. It's fairly hypoechoic, so you're really getting into a segment where you can see your landmarks a little bit better. So once we've got that image on there, so things to pay attention on your ultrasound imaging, the femoral artery. So as the probe is placed on the leg, and we're looking at the ultrasound image, it's labeled laterally. So if you were to take this block from lateral to medial, you would have to have a negotiation pathway that would kind of segment in between the femoral artery and the femur, meaning that you would have to come kind of split it perfectly in between those. So because the angle of approach can be challenging in that particular instance, I typically will take this block more commonly as a medial to lateral block, such that I don't have to worry about contacting the femoral artery, having to negotiate around the femur and femoral artery. So you kind of abduct the leg a little bit, kind of get it out, so you can get that segment of approach to get down to the sciatic nerve. So important structures to pay attention to here. So we have our femur that's identified, our femoral artery. So AMM is our adductor magnus. So again, like we're doing our obturator nerve block, we're probably in this particular image probably up a little bit higher than where we would take a conventional obturator nerve block, but the adductor segment itself is still there. And then we have the transition zone between the adductor and what is towards the bottom of the screen for ultrasound beam, which is like the gluteal muscles, is the sciatic nerves in between that plane. So as you look, as the femur is a circle, then in kind of that bottom third in that transition plane is that hyperechoic line that runs across the screen. That's where the sciatic nerve lives. So sometimes it's much more discernible than others. It's a thickened segment that you can tell it's hyperechoic, and sometimes it's just within that plane. So I've taken this block, just kind of getting into that plane and putting it in hydrosection volume, and I had success with that. But that's where the nerve lives, and you're just kind of trying to adjust your probe so you can get that image cleaned up a little bit. So in this particular approach, we're fairly high in terms of what the imaging, where we're approaching the sciatic nerve. So as we look at the ultrasound image again, you kind of see almost like a downslope, like a ski slope that runs from left to right of the femur itself as we're looking at that osseous structure. That projection medially is the lesser trochanter, okay? And so the sciatic nerve itself runs just deep and medial to that. So that's kind of one of those other structures that you're trying to get an appreciation for, because that will also kind of point to where your nerve segment's going to be. So this nerve is kind of a gremlin to stem because of the insulatory properties. A lot of the sensory segments are on the outside, and we use the Contiplex, the B-Bron Contiplex sets, and sometimes you don't get real great stem for that. I mean, you're almost like intraneural before you get any kind of stem from it. So, and typically that's, if you're trying to incorporate that as part of your procedure, just acknowledge that sometimes that segment of the sciatic gives you a stem that is a little bit hard to get to. So if I'm satisfied with the ultrasound imaging, I'll take this block without stem because it's generally pretty reproducible. We already talked about the medial to lateral approach, and try not to stick the femoral artery on the way, and that's the only real big vascular structure that tends to be there. I have seen strange, like venous congestive segments that have been superficial to the adductor magnus segment that's there. So just kind of pay attention to structures as they manifest in ultrasound, because I've seen that a couple times that is slightly concerning, and it affects how you approach that nerve, but it's not common. There's always a risk of damage to the nerve because it's a pretty discrete structure that is a sciatic nerve. This is a newer approach to the sciatic nerve that I've come across and taken favor to as a parasacral approach. So this was an article that was published in the British Journal of Anesthesia, I want to say maybe 2007. The article is referenced at the bottom of the slide. So as we're imaging, we're just below the pelvic brim in the picture that's on the left. We've got a line that's kind of projecting directly towards the greater trochanter is what is imaged there. In the ultrasound image that's immediately to the right of that, we're looking at a tapered segment of the gluteus maximus as it kind of comes up and attaches the pelvic brim. And we see a little bit thickened segment of the gluteus medius. The black on the other side is the bone that is the kind of the sacrum and pelvis deep to that. Now, as we pan down, you'll appreciate that the probe comes down and we're running along the line of the sacrum. And so if we were to shift that probe further to the patient's left, which would be medial, then we would be on osteostructures and get more kind of that blackout hypoechoic segment. But they've kind of stayed on what is thickening of the gluteus maximus, which is the ultrasound picture that we see on the right. And then just deep to that segment, you'll see this hypoechoic segment that's the piriformis. Now, looking at the cadaver image that's further on the right, okay, we see our piriformis, they've got it lifted up, and we see our sciatic nerve just deep to that, okay? Now, why all this is notable is because as we're looking at the echogenicity of the gluteus maximus that's been reflected in the cadaver image, we see the striation pattern within the gluteus maximus itself. But because of the way the piriformis is oriented in kind of an oblong fashion and doesn't give you that same reflectance, you see the piriformis as a hypoechoic structure that's just kind of this black blob just deep to the gluteus maximus, okay? Now, once you've identified and appreciated that segment, what you have deep to that is the sciatic nerve, okay? Now, also keeping in mind and looking at the cadaver dissection itself here also is that, so we have our gluteus maximus, our piriformis, our sciatic nerve just deep to that. Okay, now just deep to your sciatic nerve right there, because this is the tightest confluence of the root segments that have just given rise to the discrete sciatic nerve as a single structure, okay? Just deep to that are basically pelvic floor muscles. So I've had very thin patients that I've done this block on that, curiously enough, as we're imaging it, holding the probe still and kind of looking at those layers just deep to the sciatic nerve, the pelvic floor is right there. So I've taken this block as a kind of a superficial run to just get through the gluteus maximus, kind of on that bevel that is the piriformis, because we're almost looking at the sciatic nerve in a long axis view, okay? So as we've identified our piriformis, we can see the sciatic nerve structure on that. If we translate the picture on the left to the cadaver picture on the right, you're looking at the sciatic nerve kind of in a long axis view. So it's a great in-plane approach to get to it, to put that volume right on top of the sciatic nerve. Now, you're not going to go through the nerve itself to try to get underneath it, to hydrodissect on the other underside. So typically when I deliver this block, I'll be just putting it on the top of the sciatic nerve, okay? So experience with this block, like I said, this is the paper that I teach from, and then my experience is evolving with the application of this. This is a block I've just been doing for probably about the last 9 months or so. So the nice thing is very proximal coverage, okay? So if it's something that's like an above the knee amputation where you're also needing to get coverage of the posterior cutaneous nerve of the thigh, which I've unfortunately missed in previous blocks, you get that entirely. Because of your proximity of where the root segments are giving rise to this discrete sciatic structure, I've had a couple of patients that have had kind of translation of that injectate to root structures and have had, dermatomal type patterns of, affect. I'm numb right here, like in like lower sacral segments. So that's been an interesting kind of secondary finding in terms of what. How we're able to push that volume a little bit more proximally. I wouldn't think that this would be the parasacral, I wouldn't think would be a terribly high plasma concentration block, but this is not one of those that is, has been studied and classified, so that's kind of still of a black box. But the sciatic block itself, because of the vasculature and where it lies, is one of the least likely to give you an increased plasma concentration. But the short answer to that is we don't directly know, because I don't know that I've seen any studies or anything on it. The transgluteal sciatic is one of the more common blocks that we'll perform. So you're palpating the greater trochanter and the ischial tuberosity segment. That's just kind of the butt bone segment you're feeling kind of up under the gluteus maximus segment right there. So as we're identifying those segments, typically we'll take this block from lateral to medial, and then we're translating what we're seeing for our external to our internal imaging. That's the ultrasound. We see that on the top we're imaging our gluteus maximus or GMM. The femur, so the greater trochanter, is on screen left. The sciatic nerve always runs in this hammock between the femur and the ischial tuberosity. So you'll always see kind of these two black blobs of the osseous structures that you can feel from the outside, and you're just kind of putting your ultrasound probe right in kind of that groove in between those two firm osseous structures, and you're looking for kind of just that hyperechoic line that runs in between, where you've got your gluteus maximus on the more superficial, the top part of the screen, giving rise to what, as you're panning forward, kind of adductor segments that are just past that, and then within that plane, the sciatic nerve runs in between those. So looking at the cadaver dissection right here, there are gluteal sciatic. You can kind of see the projection of the ischial tuberosity right in that kind of that groove where the sciatic nerve is coming down, and then again kind of projecting. You see that divot, which is where the greater trochanter, and then you're looking just deep to the gluteus maximus right there. Proximal sciatic, we're also going to get our posterior cutaneous nerve of the thigh, because it won't have come off discretely at this level in most patients. Again, also kind of one of those more challenging to stem approaches because it's pretty heavily insulated. I've had one case personally where I've had a patient that was, this was not an ultrasound-assisted procedure, but it was an anatomically utilized sciatic where you identify your landmarks and pass the needle in. That because of the muscle consistency and blood vessels and things that can be feeding the gluteus maximus is a fairly large muscle. This is the only block I've had a very distinct local anesthetic toxicity with, which the textbook answer is that this is not a block that's going to give you a very high plasma concentration, but interestingly enough, it's the only one I've ever had a distinct seizure and local anesthetic toxicity from, so buyer beware. Popliteal sciatic, so this is a fairly common block that we do at our institutions for knee and things below the knee, foot and ankle surgery, things where we need the sciatic nerve itself blocked. So as we're looking at our anatomic associations here, the ultrasound probe will be placed most commonly for popliteal block, and it's the popliteal fossa. It's a sciatic nerve in the popliteal fossa. There is no popliteal nerve, okay? So don't be using the term of a popliteal nerve, because I will be very dissatisfied with your appreciation of anatomy. So you're resting the ultrasound probe largely on the biceps femoris segment, okay? As you're pushing forward, so anteriorly, you have kind of a force that you're applying against the biceps femoris, and then you should also have an appreciation of almost kind of the semitendinous muscle, which is medially, that you're pushing against as kind of a rail to keep you from going too far medially. So if you're just able to have kind of free motion on the back of the leg all the way across, generally what I'll tell our residents is that you're not applying quite enough force on the biceps femoris, which is a little bit more of a lateral structure. And then with the force applied anteriorly, something should be stopping you from going medially, and that's the semitendinous muscle. In this particular ultrasound picture that we're looking at on the right here, we see the tibial nerve identified. So that would be our medial segment, and then the common peroneal is the other segment that we're looking at on the lateral aspect, okay? So as we were to take this image up further, we would see those two structures kind of make the Mickey Mouse face come together and turn into one structure, the sciatic nerve. And then as we pan further down the leg towards the feet, in the bottom of this picture, you can have an appreciation of the popliteal artery. Okay, there is a popliteal artery, not a popliteal nerve. And that tends to have close approximation with that within the fossa and standard and anatomical views. So in our cadaver section here, there's a little bit of shifting of the ultrasound probe in terms of they're imaging this right on the semitendinous muscle. So typically, because of the orientation of this leg, it's rotated a little bit. I'll have the resonance kind of on the biceps femoris muscle, pushing medially against the semitendinous muscle, and then we're looking at the sciatic nerve, in this particular instance, common peroneal tibial nerve, as it's just deep to the biceps femoris. So you should see a line that's kind of on the top of where you're appreciating your sciatic nerve to be. That's the delineation of the biceps femoris kind of stopping, and then the nerve itself being a discrete structure just deep to that biceps femoris muscle segment. Okay, so these are our distal segments. What gives rise to the tibial and common peroneal. Also keeping in mind that the sural nerve that comes down has contributing branches from both the tibial and the common peroneal. So that was an interesting little item that I came across and kind of reinforced my knowledge base as well, is that your sural segments are contributions from tibial and common peroneal. You will miss the posterior cutaneous nerve of the thigh in this block. So if you're doing this, it's kind of a distal thing for like a below the knee or an above the knee amputation, you may be missing the posterior cutaneous nerve of the thigh. You should be using a higher approach for sciatic nerve block to not miss that segment, so the patients are uncomfortable if you're trying to use this as a sole anesthetic. So we already talked about our biceps femoris segments, our semitendinous, the popliteal artery is our landmark structures. And then if you are passing because remember, everything's backwards in this imaging. We're imaging from the front to back. If you've projected your needle too far anterior, going towards the front, okay, then you're going to run the risk of hitting those vessels that are approximated to them. All right, foot and ankle blocks. I know this is running a little bit long, so I'll try to wrap this up quickly here. So 5 nerves of the foot and ankle, our saphenous, deep peroneal, superficial peroneal, sural, and our tibial. Okay, so you guys know me that I do like the standard military teaching. When stuff's going to be on the test, I stamp my foot on the ground, okay? So the saphenous is the only one from the femoral. Everything else is from the sciatic, okay? And then the deep peroneal is the web space in between the first and second toes, okay? So looking at our cross-section of the segment here, all these drawings are going to show discrete structures for where all these structures are located. Anteriorly, the superficial peroneal nerve kind of comes out in a web-type fashion, so it's not like it's a single discrete structure. So this block is performed as a type of block where you're kind of putting in like almost a ring in the anterior segment of the ankle itself. The saphenous nerve is kind of done as a field block kind of around the saphenous vein. So it's interesting how things that are right together have the same name: saphenous vein, saphenous nerve. And then, not pictured in this picture, but in the subsequent picture, I've got pictures of approaching the tibial nerve, which is just behind the medial malleolus. Okay, and we talked about the sural nerve itself having contributions from the tibial and common peroneal segments. All right. So this is a picture taken from a website indicated on the bottom of the website. So this is the military regional anesthesia book that I like to teach our residents from. It's like cliff notes of regional anesthesia. So of those 5 nerves of the foot and ankle, this is kind of the go through. So if you guys want to kind of pause the podcast and read these more in depth, it gives you the insertion points and where you're going to be approaching all of these nerves. And so ankle blocks are largely for coverage of the branch segments below the ankle, distal foot, toe amputations. So your deep peroneal nerve is going to be kind of the inner osseous spaces between the bones of the foot. Superficial peroneal is kind of all the skin and things on top. Saphenous is kind of a medial stripe along where the saphenous vein distribution would be. Tibial nerve gets your plantar surface of the foot. And that comes from just behind the medial malleolus. And then the sural nerve has kind of a discrete stripe just on that lateral aspect of the foot. So that's where all those distribution segments are. These are largely just done as field blocks. There are textbooks that will describe, discrete places that you can use ultrasound for this. They're small nerves. They're easy to saturate with, reasonable amounts of local anesthetic. You don't necessarily have to make this block more complicated than what it needs to be. So it's not this discrete thing where you've got to put the local anesthetic in this one perfect magical spot. You get in the ballpark, the local anesthetic knows what to do. These are not big sensory nerves. We talked about the saphenous, the only segment not from the sciatic. It comes from the femoral. The deep peroneal is the web space, first and second toes. We talked about the tibial, and then we talked about the sural segment. Okay, I used Nisora for many of these photos. The rest of the ones were given reference from websites that they were just open access from what I was able to get from the internet. Used the Canadian website as well heavily and the military website. Thank you very much for your attention to this podcast, and I will conclude here.